shot or surgery is no longer a simple choice. Wegovy, Semaglutide, and Zepbound, Tirzepatide, can produce major weight loss without an operation. Surgery still delivers the largest average loss for many people with severe obesity. Zepbound comes closer to surgical results than older medications ever did. The better option depends on your target, risks, and ability to continue treatment. The central difference is how strongly each option controls hunger and how long that control lasts. Wegovy strengthens one signal that increases fullness. Zepbound strengthens two fullness signals. Surgery reduces stomach capacity and changes hunger hormones. This makes large meals harder and helps fullness last longer. Those differences explain the average weight losses. In a major trial, Wegovy produced about 15% weight loss after 16 months. Zepbound reached about 21% at its highest dose. These are averages, not promises, and individual results vary widely. For someone starting at 250 pounds, 15% is about 38 pounds, 21% is about 53 pounds. That can improve sleep apnea, mobility, blood pressure, and blood sugar. Someone with severe obesity may still need more loss to control related diseases. Weight loss surgery often produces greater loss. 5 years after sleeve surgery or gastric bypass, patients often maintain about 20 to 30% total weight loss. From 250 pounds, that is roughly 50 to 75 pounds, gastric bypass often reaches the higher end. Sleeve surgery removes most of the stomach and leaves a narrow tube. You feel full with less food, and hunger often falls. A gastric bypass creates a small stomach pouch and reroutes part of the small intestine. It usually produces more loss and better diabetes control. No single trial directly compared all three treatments. Drug and surgery studies enrolled different people and used different follow-up periods. The broad pattern remains clear. Surgery usually produces the greatest average loss. Zepbound narrows the gap more than Wegovy, but it does not erase it. The timeline also differs. Surgery usually causes rapid loss during the first year, then slows. Medication loss builds gradually as the dose rises and appetite falls. Faster loss can help when obesity-related disease worsens, but protein and strength training are needed to protect muscle. Weight loss is not the only outcome. Wegovy has reduced heart attacks and strokes in some people with obesity and existing heart disease. Long-term studies show surgery can improve diabetes and produce remission. Remission means blood sugar stays below the diabetes range without diabetes medicine, but diabetes can return. The larger surgical effect requires more preparation. The team checks heart and lung risk, nutrition, eating patterns, and medication safety. Smoking may need to stop. Uncontrolled binge eating or severe depression needs attention because surgery cannot resolve every reason someone overeats. Preparation is only the beginning. Surgery requires anesthesia, recovery, liquids before solids, and lifelong vitamin checks. Leaks, bleeding, or clots can occur. Later problems include ulcers, reflux, or dumping when food enters the small intestine too quickly. Neither choice is a short-term treatment. Stopping Wegovy can remove the appetite control that created the loss. After treatment stopped, participants regained about 2/3 of their lost weight within a year. Surgery is permanent, yet it cannot make weight regain impossible. That creates two very different commitments. With medication, you must tolerate, obtain, and afford long-term treatment. With surgery, you must accept an irreversible operation and lifelong follow-up. Choosing only by first-year weight loss ignores whether the treatment can be sustained. Medication often suits people who need substantial loss but want to avoid an operation. It may also suit people with a lower BMI or greater surgical risk. BMI compares weight with height. Dose adjustment is possible. Treatment can change when side effects, pregnancy plans, or life circumstances demand it. The common drug problems are nausea, vomiting, constipation, diarrhea, and feeling overly full. These often improve during gradual dose increases. Persistent vomiting, dehydration, severe abdominal pain, or inability to eat may prevent continued treatment. A strong medicine is not useful when someone cannot remain on it. Medication should be reassessed after a set period, not continued on hope alone. Track weight, waist, side effects, blood sugar, and daily function after reaching an effective dose. A weak response may justify changing drugs or discussing surgery. Expensive treatment without meaningful benefit should not continue. Surgery becomes more compelling when the weight target is much larger. Surgery also makes more sense when obesity has already caused serious disease. Examples include hard-to-control diabetes, severe sleep apnea, major mobility limits, or repeated medication failure. The amount of weight loss needed matters more than BMI alone. BMI is only a starting point for eligibility, not the final treatment decision. Weight loss drugs are commonly used at BMI 30 or higher. They may be used at BMI 27 with a weight-related condition. Current surgical guidelines recommend surgery at BMI 35 or higher. The needed weight loss still determines which option is strong enough. A person needing 10 to 15% loss may reach that with medication. Someone needing 30% should not assume a weekly drug will reliably deliver it. Starting with a weaker option can waste years when diabetes, sleep apnea, or joint damage is progressing. Next, consider how urgently treatment is needed. Severe or worsening disease may require a treatment that usually produces more weight loss. Someone with milder disease may reasonably start with medication. Delaying effective treatment carries risk, even when waiting feels safer than surgery. Another question is whether you need the choice to be reversible. Medication can be stopped or changed more easily. Surgery usually causes more loss, and its changes cannot simply be switched off. This matters for people who are unsure about permanent eating changes, lifelong supplements, or future pregnancy timing. Your stomach and bowel history can change which option fits. Severe reflux can make a sleeve less attractive because it may worsen reflux. Gastric bypass may improve reflux, but it changes how the body absorbs vitamins and minerals. Previous abdominal operations and bowel disease can also change the surgical plan. After the medical questions, ask whether you can keep the treatment going. Losing insurance coverage for a drug may force missed doses or stopping treatment. Surgery requires an operation and recovery, while medication creates repeated costs. Poor follow-up, lost medication access, or missed supplements make both treatments harder to sustain. Support helps both treatments last. Medication users need dose follow-up and a plan for interruptions. Surgical patients need blood tests, supplements, and rapid evaluation of vomiting or poor intake. Neither option works well when follow-up stops after weight loss begins. A practical sequence starts with the amount of loss required, not fear of surgery or excitement about a drug. Estimate how much loss is needed to improve your health. Compare that target with realistic averages. Then assess disease urgency, surgical risk, side effects, coverage, and willingness to continue treatment. The decision may involve more than one treatment. Some people use medication before surgery to lower surgical risk. Others use it after surgery when weight regain appears. Combining treatments is not failure when one treatment cannot provide enough weight control. Wegovy or Zepbound may be the better first step when the target is moderate and long-term access is realistic. Surgery may be better when severe obesity demands larger, more durable loss. The best choice is strong enough for your goal and sustainable for years afterward. Medicine, simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.